Let's go ahead and get started. Looks like our numbers have started to slow down just a little bit. So thanks everyone for joining. Happy New Year. I can't believe we're already almost halfway through the month of January already. So welcome to the Society of Thoracic Surgeons General Thoracic Surgery Database monthly webinar. Today is Wednesday, January the 10th. On the call with me today, just a small group from our side. We have from the STS team, we have Catherine Holyfield, and then from the core group, we have Katie Lothrop, and then our GTSD consultant, core group member, Ruth Riley is on today as well. So thanks everyone for joining. Agenda, again, I just have a few STS updates to provide, and then we'll turn things over to Ruth for her updates and education points. And then as usual, we'll finish things off with our Q&A session. If you have questions, please be sure to put those into the Q&A. I just shut down the chat box. So again, please be sure to put your questions into the Q&A. If you'd like, you can also raise your hand if you'd like to just ask your questions, or if you want to chat with us, we'd love to hear your voice. Just make sure your microphone is enabled on your end, and then we'll get you unmuted so you can ask your question there. All right, so let's go ahead and jump into things. The January training manual is going to be posted by the end of the month. Ruth has that completed and over to me, and we'll get that to marketing today and get them to have that posted ASAP. In a previous webinar, I had mentioned the supplemental neoadjuvant training manual that's going to be posted. I am finishing that up, and marketing will have that posted at the 1st of February. Things are kind of slammed here with STS annual meeting coming up. So marketing and communications department is completely slammed, and STS side of things, we are knee deep, eyeball deep, honestly, with annual meeting things. So we'll get that. I'll have that training manual posted at the beginning of February. And again, just a reminder, everything is currently posted. The neoadjuvant module is in the GTSD training manual. It's at the very end. There are bookmarks in the current training manual you can use to easily navigate to the neoadjuvant training manual, the neoadjuvant questions, guidance there. But yeah, I'm just going to be pulling that out into a separate training manual just to make things easier for you all. And so that'll be available in the beginning of February. If you have any questions, again, just please let us know. And I'll announce more information on that on our February webinar. The fall 23 harvest analysis, as you're aware, was complete and the reports were posted. We sent out a communication to all the participants on November the 21st. Just a friendly reminder, any report-related questions should be directed to STSDB_helpdesk at sts.org. So if you have any questions about your report, access, any type of questions related to that report release, please email the help desk first. And if they cannot answer your questions, they will get you in touch. The question will either be sent to me for a response or to IQVIA for a response as needed. Also, just a reminder that if you haven't been out to the IQVIA library since that report release, there is a new version of the analysis overview that is posted. So just make sure that you do have the current version. The most recent version is dated November 17, 2023. The biggest, not a lot of changes were made, but there were some updates made to the inclusion-exclusion criteria for the lobectomy and esophagectomy populations. This is nothing new. So there's not any new inclusion or exclusion criteria that was applied. It's just being a little bit more transparent upon inclusion and exclusions that happen on the analysis side of things. So if you have any questions, if you want to know why a case wasn't perhaps included in your lobectomy composite or esophagectomy composite, we're just making that inclusion exclusion criteria just a little bit more clear, laying out all the steps of the inclusion criteria and exclusion criteria that happen on the analysis side of things. Again, nothing new from previous analysis. We're just making it that criteria a little bit more transparent and more clear on what happens in terms of inclusion and exclusion criteria in the analysis. GTSD public reporting update. Our next update is scheduled to take place the first week of February. And that public reporting update will include the results from the fall 23 analysis. If you have any questions regarding public reporting, please let us know. But again, the next update is scheduled to take place the first week of February. I would suspect closer towards the end of that week. So let your surgeons, your teams know that the next update will be taking place that first week of February. The spring 24 harvest is currently underway. We are accepting surgery dates of 1/1/2021 up through 12/31/2023. Speaking of the 2024 harvest dates, the harvest schedule has been posted and is out on the STS website. I did include it here in case you wanted to take a snippet or print out the slide, post it at your desk. The slide deck obviously will be available and posted out on the STS webinars page here after this, hopefully by the end of this week, more likely the first of next week. But the harvest schedule is posted out on the STS website as well, if you would like to access it via that method as well. Also, for those of you that may be new, we have any new data managers joining us this year, or if you haven't heard yet, 2024 AQO data managers meeting, we are going back in person, and we will be in Nashville, Tennessee this year. We are so looking forward to being back in person. We hope you all can join us. The dates for 2024 AQO are a little bit earlier this year as opposed to last year. So AQO this year will be September 10th through the 13th. And again, we will be live and in person in Music City in Nashville, Tennessee. Really looking forward to seeing everyone there in person and getting things back, quote, to normal. So we are looking forward to seeing those of you that can join us in Nashville, Tennessee this year. I think that is all that I have for STS updates at this time. I'm going to turn things over to Ruth so she can present her education points. So Ruth, the floor is yours.
Thanks, Leanne. There are just a few quick updates that will be published in the January training manual that I wanted to go over. There are additional updates beyond these, but pretty straightforward. So the first sequence that we're going to review is sequence 1620, clinical staging methods. A question was posed, can CT guided biopsies performed within 4 months of any treatment be captured as CT in clinical staging methods? And the answer to that is yes. I'm going to go to the next slide. So we tried to do, there was some concern raised about the changes that had been made to sequence 650 history of cancer, specifically looking at coexisting cancers and how that is defined. So we tried to clean this up. We talked about this pretty extensively at the core group, and the decision was made that coexisting cancers can now include synchronous primary lung cancers, which is currently listed as an exclusion up in the body of the definition for coexisting cancers. And then I lined through the September 2023 update so that we could keep everything consistent. So now if you have a synchronous primary lung cancers, they are captured as coexisting cancers for sequence 650. And then the last sort of screenshot that I wanted to share is something that was put together by Ann Higgins. So shout out to Ann for this great summary. Sequence 4290, which is consistently problematic. I'm not going to read through this, but you'll have it available for reference now. I'll post it in the training manual, and then it'll, of course, also be in this webinar. But it's essentially all of the possible scenarios for how you would answer yes or no to sequence 4290, which is substance use screening and counseling. The one thing that's not mentioned on this little algorithm, excuse me, which is exceptionally rare, is patients for patients that screening can't be performed for, which is, I think the option to choose is not applicable. Not applicable is really only intended to be used for patients who are cognitively unable to be screened for substance use or receive counseling. So it's almost never used. So this goes through all of the very common scenarios. And that's all of my updates that I have.
I'm sitting here talking to myself on mute. Sorry about that. Thank you so much, Ruth. I know we have some questions coming in. Before we jump to those questions, I'm gonna hop over to our upcoming GTSD webinars. So our next few webinars, we have our monthly webinars coming up February 14th, March 13th, and April 10th. In the new year, we're no longer going to continue with the user group calls. We're going to have our monthly webinars, and then we are not going to continue with the user group calls, but we will continue to have, we will have another monthly call in the future. Not the webinar, but another data manager related call. We are revamping, and I don't know if I've mentioned this in our previous, in any of our previous webinars, but STS, we're currently revamping our mentor-mentee program. And so more information will be coming out about that in the coming months. Addie Dolan here at the STS is handling handles the mentor-mentee program. So again, we're totally revamping that. So we have a lot of new exciting ideas, and the program, we're excited to introduce that to you. So we're in the process of, finalizing how this program is going to work, getting all the details together. So again, we'll have more information for you in the near future, and we'll be utilizing those times when we had our user group calls to help support this new mentor-mentee program. So again, more information coming in the future, but moving forward right now, the only webinars for GTSD that we'll have right now moving forward will be our monthly webinars. And again, they're the second Wednesday of every month from 2:30 to 3:30 Central. So again, I just put those our next 3 monthly webinars on this slide for you. All right, so let's go ahead and hop into our questions that we have. All right, let's tackle our first one. First question from Nancy. When will AQO meeting be posted so we can start to budget? Nancy, I assume you're talking about AQO fees. I do not have those at this time. I need to meet with our meetings team and education team to get more information on when that'll be available. I know we are going to start planning the agenda, I believe next month. So we are starting to work on that, but more information will be forthcoming. We do have the dates, September 10th through the 13th, and the location, but again, more information will be shared with you all as soon as I get it from our meetings and marketing team. So we'll have more information ASAP. Sorry, I can't provide you with that with a definite time, Nancy, but I'll share as soon as I can. Next question from Donna. When again are we supposed to start answering the neoadjuvant questions? So that we had the temporary fields were utilized for our first 2 neoadjuvant fields. Those went active as of October the 1st of 2023. So beginning with surgery dates of October 1, 2023 forward, you should answer those temporary text fields. Those were presented in in our October webinar. We had a presentation, and that recording is posted out on the STS website if you'd like to go back and review. Dr. Cedar, our GTSD task force chair, presented on that webinar, giving the purpose of those 2 fields, why we're starting to collect this neoadjuvant information. So I suggest, recommend going back and reviewing that October webinar. If you need help locating that, just give me a shout, shoot me an email, and I'm happy to point you in the right direction. But it is located on the STS webinars page as well as the STS YouTube page. So again, those 2 temporary text fields should went active October 1, 2023. And then beginning with November 1st of 2023, participants, if you elect to do so, it's a completely voluntary module. We have those additional questions on the REDCap form. So again, there's 2 webinars talking about the temporary text field. There's that October webinar. And then in November, we had a presentation on the REDCap module and those additional variables and additional data that we're collecting in REDCap. New data manager here. Are we able to start submitting the optional case types at any time, or is there a deadline for deciding to do so? No, Cassie, you can submit those optional cases at any time. No type of deadline or anything there. And if you have any other questions, Cassie, please feel free to reach out to myself and Ruth and I are happy to assist in any way. help you get your feet off the ground. Let's see here. Just to be clear, webinar times are Central Time Zone. Yes, so webinar times are Central Time Zone. Sorry, thank you for clarifying that. I think I had that on the webinar. Yes, so the webinars are Central Time Zone. All right, next question. National Database Surgeon Level Reports now available. So surgeons can get individual report along with our institution. Can data managers download them as we do for our hospital? No. So these surgeon level reports that are available are strictly for your surgeon only. Your surgeon does have to sign a consent to get this report. And this report, the surgeon level report right now is mainly just giving them counts, procedure types, how many surgeries they have in the database. This is strictly, again, a surgeon level report. They must sign a consent to get this report. And this report is only available to your surgeon directly. Data managers are not able to access these reports. So Kelly, if your surgeon has questions, please have them email me directly, or they can reach out to stsdb@sts.org for more information on the surgeon level reports. Happy to help. But again, that report is only available for the surgeon themselves. Data managers do not have access to those reports. Do you know if there will be a virtual option for 2024 AQO? Yes, so there will be a virtual option for AQO 2024. We will not have, concurrent live streaming. It'll be in the same manner that we've had virtual component before for our for the Rhode Island AQO. So we'll have more information on that, Beth, but we will have a virtual component for any of those that are not able to join us in person. All right, Ruth, this looks like maybe one for you. Sequence 590, AFib within 1 year. Does that mean a documented episode or just documentation of AFib history within the year?
Let me pull up the training manual so I don't violate these rules.
While you're doing that, I'll see if there's some other emails or some other questions I can adjust. Let's see. From Amy. Yeah.
Oh, go ahead.
Webinar dates.
Go ahead.
Go ahead.
I was going to say, one of the data managers asked if you could go out to the STS website and show where the recordings are. They're specifically looking for the recording on how to review your harvest report, which I think is a presentation that was given by Katie.
Sure thing. So, see, not YouTube. Sorry, guys. So let me go here to sts.org user. So from the STS website, for STS National Database, here, STS homepage, I typically click on, to get there the most quickly, click on the link down here for Data Manager. You can get here many different ways. This will bring you to the Data Manager homepage. If you click on Resources for Data Managers, this link here, scroll down to General Thoracic Surgery Database. You'll see it'll bring you here to the General Thoracic Surgery Database section. You'll see GTSD webinars. Here's the link for today's webinar. This will come down. I'll work with marketing to get this taken down. And then there's also in this box here, you have our most recent webinar recordings. You can view the slides here for our new Data Manager webinar, the neoadjuvant, then our monthly October and September. These are just the slides. We have the one webinar recording here from our most recent webinar. It was very confusing. I'm so sorry. I was talking in circles there. Long story short, to view past GTSD webinars, click this button here and it'll take you out to our GTSD webinar page. And all of our previous webinars are located here. I don't know, Katie, do you remember which webinar that was that you did the report of, you walked through the report?
The analysis overview?
Yes, ma'am.
Hang on one second.
Yeah, I can't remember off the top of my head which webinar it was where you walked through the report on the IQVIA website and just gave a, like, how to understand it.
It would have been Maybe oh hell, I don't know.
Yeah, I know. It was
Harvest
maybe.
well, this says July of 2022. Was it really that long ago?
Oh my gosh, maybe. May have been.
It's probably that GTSD monthly webinar, July 13, that one.
Yeah, maybe. I'll look around, and I'll go through and look around, but if you
Mine says it was a user group call, and I
okay.
think it was the 27th, July 27th, maybe.
Okay. Yeah, so maybe this one here.
That would be my best guess.
Okay. Yeah, I would start with it. Yeah, start there. And if you still can't find, I'll look too, and I'll make a note of it. So I have it for future questions. So I'll make a note of it. So yeah. And then while I am
sorry, I don't know. Can you go back to the resources for data managers page? Can we add like a link to that video under
here?
Like it'd be a great tool for new data managers. You know what I mean? Like it would be nice if we linked it somewhere permanently.
Yeah,
for consideration. I don't know.
Yeah, I can talk to marketing. I know they limited us to one recording link here, which
yeah, that's a bummer.
Yeah. And we were able to at least get them to post the slides here and not multiple recordings, but I'll see what I can do. And maybe at a minimum, we can maybe link it in the training manual or on the very first page for quick resources, quick links. Maybe we can do it that way. Since I'm out on the STS website, or since I'm out here, Nicole asked, can you show us where to find the analysis overview for inclusion? Yes, so the analysis overview is actually found in the IQVIA platform. Oh, for the love. Oh, hold on, let me get my little authentication code and I can enter this.
That's how we all feel, Leanne.
I know. It drives me bonkers, but got to do what we got to do. All right, so if you go out into the IQVIA platform, click on the link for library, and the very first document here is the National Report Analysis Overview. And again, make sure you have this is the current one. It's dated November 17, 2023. And the document is here, actually, so just there, I already have it. So what I can do is I can just pull over and I can show you briefly some of the updates that were made. So we had, and also note that there are the bookmarks here to help you easily navigate. The document. So I'm trying to see here. Here, a couple of the updates, some things that you'll see. We elaborated on the exclusion criteria here. You'll note some new information, patients with occult or stage 0. We just made it a bit more descriptive, again, more transparent, so you can see, you know, what all happens in the background in the analysis. Again, this is nothing new. This is just more descriptive information of things that have always been done in the analysis. So we're just, again, just being more transparent to help you easily identify cases, you know, that may or may not have been included or excluded into the analysis. So again, this is where you'll find the changes under the patient, the patient population for the composites. All right. Yes, I agree. It would be nice if the webinars had a description. I know they used to. I will work with marketing as they handle all of that. So I will definitely take that back to them. It would be extremely useful. I agree 100% if we could get a brief description on the webinars that are actually posted. I agree. So I'll definitely take that back. So, all right. All right, Ruth, do you want to get back to our AFib question?
Sure. So they have to have, so according to the definition for sequence 9590, which let me scroll back up to so I can read it. It's number 4, sub-bullet D. So it includes patients with persistent or paroxysmal AFib if present within the last year per provider documentation. So they have to have had persistent or paroxysmal AFib in that last year, not a documented history of AFib at some point in their past life that was documented in the past year, if that makes sense. One question that I get quite often is why the time frame for sequence 590's definition of AFib does not line up with the post-op event timeline for AFib, and they're intentionally just different. So the two they're not related.
All right. Next question. Sequence 1800 nodule size instructions say GGO should be given size of 0, which solicits a warning on the DCF. Also, if I don't know what GGO stands for, I'm sure I should know. Size 1.8 on, my questions are jumping around. On radiology report, and surgeon lists tumor size of 1.8, for example, but doesn't mention if it was solid or not. Which should we take?
So on the topic of warnings, it's okay to ignore a warning. The point of the warning is just to get you to make sure that you really intended to enter the value that has been entered, because it's not a common value. So you'll get warnings for things like number of lymph nodes all the time. And it's okay to be over that usual number if that's truly the number of lymph nodes that was harvested, for example, or in this case, if you have a pure ground glass opacity, enter the 0 and just proceed on through the warning. If your surgeon's documentation is unclear to you, I would clarify that with your surgeon, and just send them a quick message and say, was this purely ground glass? And they'll say yes or no, and then you'll be able to abstract that information. Would be the best course of action.
All right. Next question from Anne. On the path report, it often lists the lymph nodes that the surgeon sent and if they are malignant or not, but lower on the report where it lists total nodes, it will list nodes not sent by the surgeon. Has anyone come across this, and how do you code lymph nodes examined?
My guess is what they're giving you, Anne, is a summary of previous. So like if you have a patient who had a lymph node resection prior to their surgery, they might be pulling in lymph nodes from a previous resection and summarizing that for you, which is kind of them. And so you would take the summarized total, or you take the summarized information, essentially. I don't know if that's necessarily the case without seeing the total path report, but that's my guess, is that they're summarizing data points for you.
Okay.
Yeah, this is Katie. It could also be that they are the lymph nodes that are within the lung tissue, because the surgeons aren't going to necessarily be harvesting those. That's when they take the lobectomy or segmentectomy or whatever it is. There are often, lymph nodes that are living in that tissue. And so when the pathologist dissects that, they're going to pull those out. So sometimes those aren't listed separately in the top portion of your path report, but they will be listed lower down in the synopsis. But you do want to include those. So that could also, I see that often on mine. So that could be also what you're seeing.
Thanks, Katie and Ruth. So Ruth, the neoadjuvant question, are they for immunotherapy only, or patients who had both chemo, or for patients who had chemo and immunotherapy?
Are they talking about the red cap?
Yeah, let's see. Mindy, can you clarify, are you talking about the temp text fields or the red cap? Let's see, next question. I don't think Mindy is responding. Temp text. I was just talking about both.
The sequence 4580, which is the temp yes, no, is did the patient receive induction immunotherapy or a targeted agent, which is not chemotherapy. They're looking for, there's a list. I don't have it pulled up.
Hold on, let me see.
There's like the immunotherapy, targeted therapies, list of drugs that we presented in the past. It's in the webinar where we talked about this, but sorry, I don't have it pulled up. And
Okay, yeah, so it's in the webinar. Let me pull this over. It's you can access it here on the slides are located here, and then the webinar recording, if you go click on past GTSD webinars, it's this one dated the neoadjuvant therapy October. And then Laura was asking if the temp fields were for pre-operative treatment. Training manual doesn't directly mention this.
So the temp field, it's induction. I believe it's on here. Scrolling up just to look at the text of the temp fields. Yeah, did the patient receive induction immunotherapy? So that would be prior to surgery.
Yeah.
I just wanted to make sure the words were actually there.
Yeah. No worries. Tammy, love support the mental. Yeah. So the new program that's gonna be coming out. I know we currently have, and we're working through, how we currently have mentors and mentees, connected, and people have submitted for a mentor. Clearly our mentees outweigh our number of mentors that we currently have right now. So with the new program, we will be that will be going out to everyone to submit, whether they it's going to be more of a collaboration and not specifically one person who's going to be a mentor. It's going to be, think more of a collaborative type of environment. So again, more information coming there. We won't have like a one person designated as a mentor. We'll have kind of like a more collaborative environment of people working together, and that type of, that's the idea of behind the program that we're going to be initiating. So again, more information coming out. There will be a request, an email that goes out to all data managers about the program. So everyone will have an opportunity to participate. So more information about that coming very, very soon within the coming months. So we want to get that kicked off as soon as possible this year. All right, Anna. But yeah, that will be going out to all data managers. All right, from AJ. So for synchronous primary for coexisting cancer, question. If the patient has bilateral primary, okay, I assume that's bilateral. I don't know.
Yeah, bilateral primary.
Look at me. Look at me.
Yeah,
I'm gonna be a nurse before you guys know it. If the patient has bilateral primary and only one being treated now till December 31st, 2023 cases, we say no. And from Jan 1st, 2024 cases, we say yes.
That is correct. And we intentionally held this update till January 1st, hoping that the clean break in the calendar year would make it a little bit less onerous for sites that are using this data internally. My apologies for the change.
Yes, but we definitely wanted to start it at the new year so we could have a clean break, like you said. All right. Let's see here. So sequence 580 is gastrus devascularization, robotic abdomen counted as yes to prior surgical history.
So it would depend on what the surgery that's currently being performed is. And then sequence 580, if you look in the training, the July 2022 update is going to be really helpful for you. So you first have to determine if the operation that's currently being performed is in the same anatomic space. So you'll have to compare your prior surgery to your current surgery. And then if that is true, you'll have to go on to step 2, which is to look at your current op note to see if there's documentation indicating increased difficulty or complexity of your current procedure because of that previous surgery that was performed. I think Leanne's scrolling there. There you go. So that July 2022. And then there's, if you scroll down a little bit more, Leanne, there's a picture of the different anatomic cavities, which may or may not be helpful.
Perfect.
And sometimes patients you'll see in a note that a patient has increased complexity due to adhesions, for example, but those adhesions aren't from a prior surgery. So you would code no to 590. So just having one or just having option 2 in isolation does not meet the criteria to code. And I said 590, I meant 580. I'm sorry.
Okay. Let's see. Are chest tubes during lobectomy to be coded as a separate procedure?
Not generally, no.
Great. For sequence 790, if a patient that chews cigars, would this count? I wasn't sure if that was only smoked tobacco. So let's go to 790. History of substance abuse. Chews cigars. That's interesting.
I would think that it would count. I mean, smokeless
Cigars
cans is included.
Yeah.
Smokeless can, I mean, that's close to chewing tobacco, which I think is what smokeless cans are. So I'd say yes, it's any tobacco product. So.
Okay. Alrighty. Agree. Oh, Anne was just clarifying regarding the node. Sometimes it'll say they are from previous procedures, other times not. So if there are more stations noted, I would include them as well. Oh, disregard. Got it. Sorry, Ann. All right. Next from Nicole, bronchoscopy done for ETT placement. Would we capture 31622 as a procedure? I thought in past version we did not, but nothing mentioned in new version. What is 31? Bronch diagnostic with or without?
We have never counted 31622 for bronchs that are only done to verify placement of the tube. It's really not a diagnostic bronch, but I don't know. I'm scrolling to see if I wrote anything down that's different or if Katie remembers anything different. I think, is anyone else from the core group? I know Katie's on.
Yeah.
Yeah. Is this, I mean, if they're okay, would we capture as procedure? So I guess including that in your in your list of procedures, I always include my bronchs as a listed procedure. If it's listed in the op note, then I include it as a procedure.
Okay.
I think the issue before was people were capturing all bronchs for clinical staging. And that's not, we don't even do that anymore. So, but I capture it. If a bronch is listed as a procedure, then I capture it.
The core group meets on Friday. Why don't we take this one there and then I'll put a firm answer in the training manual for February. Does that sound fair, Katie?
Yeah.
Great.
An update coming your way soon, Nicole.
All right, next. My surgeon has a lobectomy that has no therapeutic intent, but a palliative intent. Final path came back as a primary lung cancer. Is this procedure still included for submission?
I would. This is Katie. I would include it. It's not going to end up, if it's truly palliative, it's not going to end up in the composite because those are only elective, but
Sure.
You would still include it and submit it.
All right. All right. Oh, my questions are jumping all over the place. What if the patient is currently treated for AFib and non-prescription anticoag, so they are not in AFib currently, but are currently being treated? And maybe we have not had a documented AFib in the previous year. Would that not be a history of AFib?
Hang on, let me go back to the section. Here, you want to go on to the next question?
Yeah, well, yeah, this one, I was just reading it. For esophagectomy composite, quality rating details, unexpected return to OR specifies only includes anastomotic leaks requiring surgical intervention. If a patient returned to OR for an intercutaneous fistula GI bleed requiring segmental, oh, y'all are making me say big words today. Jejunal resect anastomosis case is not coded as an anastomotic leak, only returned to OR for bleeding. However, it appears in the quality report as a return to OR.
Case is not. Well, it looks like you coded a return to OR for bleeding, so it would appear in your quality report as a return to the OR.
Yeah. If you want to submit, yeah, if you have further questions, we need to look at how the case is coded in the database, just please, you can submit that to the STSDB_help desk, and then we can have our analytics team, or we can have IQVIA look at how the case is actually coded and why it is being reported as it's being reported. Mindy, she's confused. She thought it was thought it was to collect patients who only had immunotherapy, but after I looked into it again, it looks like both.
I wonder if Mindy's talking about the red cap. So the way that, or my understanding from Dr. Cedar, I guess, is the way that most of these new treatment protocols are administered is it's a chemotherapy agent plus immunotherapy. So you will see chemotherapy agents, but it's like in conjunction with immunotherapy.
Okay, so here's another rec question. Oh, are you able to answer Tracy's question above, Ruth, about AFib, or do you want to?
Oh, sorry, no, I got distracted by the question about the return to OR. I'm sorry.
You're fine. All right. Mary was, when we get back, going back to coding 31622, she's saying that they were trained to include 31622 at UPMC. So, okay. Next question. For the RevCap question, PDL 1%, is this for the pre-op or post-op final pathology? And for the mutations and genes identified, if there are no mutations, do we leave this blank? Did we address that in the, let's see. Okay, so PDL 1 should be taken from the final addended pathology report.
But I think what happened is he has probably two final pathology reports because he has the final from his pre-op. Honestly, I've never seen them sent for PDL1 testing twice. Maybe we should check with Dr. Cedar and see what his thoughts are, and we can put it in the new module,
Yeah. Yes. Yeah, Joe, he's saying pre and post-op.
Yeah. Yeah, they usually don't have two PDL1 scores. At least I haven't seen that.
Yeah, he said he had two. So yeah, we can ask Dr. Cedar on Friday.
Yeah.
All right.
And it might be like a take the low or the high, you know what I mean? Not the
yeah. Yeah, and then we can I can add that to the supplement so we can make sure that's addressed. Tracy, right, the red cap form will not let you leave PDL blank. So do we enter 0 if it's not on the path report?
Interesting question.
Well, you should answer. It says we have a valid range from 0. So yes, so you would enter 0.
But that implies that the patient was tested for PDL1 and her patient wasn't tested for PDL1. Okay. So I think we should add that to our list of things for Dr. Cedar. Sorry.
Okay. No, nope, you're good. That's why we're here. We're a team. We got to keep each other straight. All right, perfect. All righty.
Laura's question for sequence 2540 and 2550, is there a time frame for pre-op IVIG and plasmapheresis? We took that to the core group and we were unable to come to a conclusion. The task force will be addressing your question in February. I'm sorry for the delay, Laura.
Yeah, we've
we did go over it.
Yeah, and we didn't have a couple of task force calls. So if it's been, a month, I can't remember when this question was asked, but we've had a couple of cancellations of task force calls. So that's also another reason for a delay if you asked that, like a month or two ago. Let's see here. Okay, if there are procedures that you list under other or other minor procedure and you don't know what the code, can you put unknown? If not, what is the recommendation? How do you guys typically handle that, Ruth or Katie?
You can usually find one on Google, but I don't know. Katie, have you run into this?
Which one are we on?
We're on from 8. If there are procedures that you list under other or other minor procedure and you don't know the code, can you put unknown? If not, you know, what is the recommendation? How do you guys typically, if you don't have a code and you list other or other minor procedure, what do you usually put for the specify field?
I look it up.
Right.
I have a coding database that I use to look it up. So I think in the field where you have where you type it out like it's letters, you know, typing out what it is, then you might be able to type in unknown. I don't think it's gonna it's not gonna give you an error or anything. I think it will give you a missing data if you leave it blank. But as far as the code, I guess my best suggestion would be to look it up, or to, if you don't have a way to look it up, maybe phone a friend or contact your surgeon's office. I'm sure they have someone in billing that might be able to find the code for you. That would be my best suggestion.
Thank you, Katie. Ruth. And Amy was saying she also runs into the same scenario with the PDL question. So yeah, that is a great question, and we'll talk to Dr. Cedar on Friday about that. All right, back to the AFib question.
So the way that I interpret the information in the training manual is the patient has to have actually been in AFib within the prior year, not just on a treatment for AFib, but I'd be curious to know what Katie's thoughts are.
This is on the AFib question.
Yeah.
Sequence.
So, oh, go ahead.
Yeah. No, I just say sequence 590 AFib specifically, not the post-op AFib.
Oh, okay. Yeah, I think the intent was changing this because historically we've always just, if there's a history of AFib, then you capture it. And then this version, they specifically put the 1 year time frame on it. So you can still have a patient that has a history of AFib in their past, but if there's no documentation, even if they are medicated, then I would just answer no. However, if you do have that, if that same patient then has a postoperative event that includes AFib, you would mark no, because again, as Ruth mentioned earlier, these questions, while they're both AFib, they aren't connected in that regard. So even if you answer no to sequence 590 or whatever that is, you can still answer no to the AFib post-op event if they get AFib, if that makes sense. So I guess short answer, if there is no documentation that the patient has had AFib in the past year, then I would mark no. That's what I would do. That's how I interpret this FAQ.
That's how I also have interpreted.
All right. Thank you, Katie and Ruth. And then just a couple of statements here. PDL reports are nearly always an addendum. They're run after the fact. And then I think this is Mary, her analysts have CPT coding books to use, as well as the online resources. So thank you for sharing that. All right. Okie dokie. Not okay. We have one more question. Is diagnosis of mild CAD sufficient for a PMH of CAD?
There are very specific guidelines in the training manual.
Is it pre-op?
Yeah. If they have a documentation of CAD in their H&P, you can capture, is my interpretation. The only caveat to that is that a radiologist's documentation of coronary artery calcification on a CT report is not equivalent to, is not sufficient to code yes to CAD. So you can't use your radiology report. So you would need in your H&P from your physician.
Yeah.
In order to capture.
All right. Any other questions? Again, I'll have more information to share about AQO 2024 as soon as I receive that from our meetings team, we'll share more information there. If you're interested in helping plan AQO 2024, we would love to have you on the planning committee. The more new faces we can have on there, the better. I know you guys, the more ideas we can get for content, please share that as well. Again, if you are interested in being on the planning committee, we'll probably have, it's not a huge time requirement. We have 2 to 3 meetings beforehand. Our very first meeting is typically just a brainstorming session where we all just sit on a 1-hour call and throw out ideas. We look at evaluations from the previous AQO for ideas. So we have a 1-hour session there. Then we typically have another meeting to kind of tighten up the agenda, solidify some topics, speakers, and then after that, if still needed, we'll have one more planning call to get the agenda finalized. And so typically, definitely no more than, I don't think we've ever had 4 meetings since I've been planning AQO, but definitely 2 to 3 meetings for AQO planning. So if you're interested in joining that committee, please feel free to shoot me an email. We'd love to add you to the list. All right. And again, I'll share more AQO information ASAP. As soon as we have that to share, I'll get that out and available for you, Nancy, so you can start working on your budget. And again, just a reminder, our moving forward, we'll just have our monthly webinars on February 14th, 13th, and April the 10th from 2:30 to 3:30 Central Time. And also, if you have any questions, again, here's my contact information. Please feel free to reach out to me directly. Happy to help in any way. Please reach out to our help desk if you have any harvest and report related questions, and then our database operational team if you have any questions regarding invoices, fees, database participation, contracts. Please reach out to stsdb@sts.org. If you're not sure who to contact, just reach out to me directly and I'll get you in touch with, get you pointed in the right direction. All right. I think we can go ahead and wrap it up a few minutes early today. Give you guys back 5 minutes of your day. Thank you, Katie, Ruth, Catherine, for joining today, helping. Great webinar. Thanks for answering all the questions. You guys are amazing. I appreciate having you guys on. Thanks for all your help. I hope you guys have a great rest of your week, and I hope you guys have a happy new year. And I am counting down until summer. So hope you guys have a great rest of the week. And thanks again, Katie and Ruth. I appreciate you guys.